Hi, I'm Dr. Shannon Signorino, PSC. I want to talk to you today about the difference between osteoarthritis and rheumatoid arthritis. When you hear the word arthritis, you most likely think of joint pain. This is a common and often debilitating symptom that millions of people experience. However, not all arthritis is the same. The term is really just an umbrella for conditions that cause inflammation in the joints. Two of the most common types are rheumatoid arthritis and osteoarthritis. People often confuse them because they both can cause stiffness, swelling, and pain. But underneath the surface, these two conditions are fundamentally different. They start for different reasons, they affect the body in different ways, and they require completely different approaches to treatment and management. Understanding these differences is the first critical step toward getting the right diagnosis and finding the most effective path to relief. First of all, I want the patient to be able to recognize if they have morning stiffness more in the morning or more at night. Rheumatoid arthritis is generally morning stiffness in the morning in the small joints of the hands and the feet. Osteoarthritis is generally at night after weight-bearing on joints closing the space between the bones, causing pain from wear and tear. Rheumatoid arthritis is a case of mistaken identity by the immune system, leading to a body-wide issue. Osteoarthritis is a mechanical problem, a localized issue of wear and tear on specific parts. While both result in damage, the source of that damage dictates everything that follows, from the tests a doctor will order to the medications prescribed. For instance, rheumatoid arthritis tends to be symmetrical, meaning if your right wrist is affected, your left one probably is too. It often starts in the smaller joints, like those in your hands and feet, called MCPs and MTPs. Osteoarthritis, on the other hand, might only affect one knee or one hip, often a larger weight-bearing joint that has seen a lot of use over the years. Like if you always spin on your right knee when dancing, generally you'll have osteoarthritis in that right knee first. Now we will explore how they are diagnosed, from sophisticated blood tests to simple X-rays. And we will look at the modern treatments that are helping people manage these very different diseases, allowing them to live fuller, more active lives despite their diagnosis. It is an autoimmune disorder. This means your immune system, which is designed to protect you from invaders like bacteria and viruses, gets confused. It mistakenly identifies the lining of your joints, called the synovium, as a threat. In response, it launches a full-scale attack. This attack causes inflammation, which leads to the swelling, warmth, redness, and pain that are the hallmarks of an RA flare-up. Because the immune system operates throughout your body, RA is considered a systemic disease. It can affect not just your joints, but also your skin, eyes, lungs, heart, and blood vessels. To me, systemic means traveling throughout your blood to anywhere in your body. That's any organ including skin, your heart, your lungs, your kidneys, and your brain. It becomes very hard to treat rheumatoid arthritis when a patient has diabetes, and vice versa. The joints most commonly affected by rheumatoid arthritis are the small ones. Think of the knuckles in your hands, the joints in your wrists, and the balls of your feet. As I mentioned, a key feature is symmetry. If the joints in your right hand are inflamed, it is highly likely the same joints in your left hand will be as well. This symmetrical pattern is a major clue that we are dealing with a systemic issue rather than a localized mechanical one. For children who develop a form of this, known as juvenile idiopathic arthritis, the knees are often one of the first joints to show signs of trouble, which can be a different presentation than what we typically see in adults. To diagnose RA, doctors rely on a combination of a physical exam, your medical history, and specific laboratory tests. We look for certain markers in your blood that indicate systemic inflammation. A test called the sedimentation rate, or SCD rate, and another called C-reactive protein, or CRP, can tell us if there is inflammation somewhere in the body. More specific tests look for antibodies that are often present in people with RA. These include the rheumatoid factor, or RF, and the anti-cyclic citrullinated peptide, or CCP antibody. A positive result on these tests makes an RA diagnosis much more likely, but it's not the whole story. It is also very important to understand that a negative blood test does not automatically rule out rheumatoid arthritis. I hear this from patients from their primary care doctors more than I would like to. In fact, about 30% of people with RA will test negative for both rheumatoid factor and CCP antibodies. It is just as important to treat these patients as the ones that are rheumatoid factor positive. The destruction will happen. This is a condition we call seronegative rheumatoid arthritis. This is why imaging plays such a crucial role. We will take X-rays, typically of the hands and feet in adults, to look for specific signs of RA. We are looking for something called erosions, which are little areas where the inflammation has actually started to eat away at the bone. This evidence of damage, even with negative blood tests, can help confirm the diagnosis. Osteoarthritis, often called OA, tells a very different story. This is not a tale of an immune system gone rogue. Instead, osteoarthritis is what we call a degenerative joint disease. Think of it as a mechanical problem. Over a lifetime of movement, or perhaps due to a past injury, the protective cartilage that cushions the ends of your bones can wear down. Cartilage is a firm, slippery tissue that allows your joints to glide smoothly. When it deteriorates, the smooth surface becomes rough. Eventually, you can get to a point where there is bone rubbing directly on bone. This friction is what causes the pain, stiffness, and loss of flexibility associated with OA. Unlike the systemic nature of rheumatoid arthritis, osteoarthritis is typically localized. It affects the specific joints that have undergone the most stress or wear. This is why we see it most often in the larger, weight-bearing joints. The knees and hips are very common sites for osteoarthritis. It can also appear in the spine and, just like RA, in the small joints of the fingers. However, in the fingers, it tends to affect the joints closest to the fingertips, whereas RA is more common in the knuckles. It is a disease of use, which is why risk factors include aging, obesity, which puts more stress on the joints, and previous joint injuries. The diagnosis of osteoarthritis relies much more heavily on your symptoms and on imaging. Blood tests are not used to diagnose OA because this is not a systemic inflammatory condition. There are no specific biomarkers for osteoarthritis in the blood. A doctor will listen to your description of the pain, examine the affected joint for tenderness and reduced range of motion, and listen for a grating sensation called crepitus. The definitive diagnosis, however, usually comes from an X-ray. On an X-ray of an arthritic joint, we can clearly see the physical changes. The most prominent sign is a narrowing of the space between the bones, which indicates the loss of cartilage. We might also see other signs on the X-ray that point to osteoarthritis. These can include bone spurs, which are little bony projections that can form around the affected joint as the body tries to repair itself. We might also see hardening of the bone just beneath the cartilage. These physical, visible changes on an X-ray, combined with the patient's symptoms, are what allow a doctor to confidently diagnose osteoarthritis. It is a straightforward picture of mechanical damage, very different from the subtle, systemic clues we hunt for when we suspect rheumatoid arthritis. The diagnostic path is simpler because the disease itself is more of a localized, structural problem. Because rheumatoid arthritis and osteoarthritis are fundamentally different diseases, their treatments are aimed at completely different targets. For osteoarthritis, the goal is to manage the symptoms, primarily the pain and loss of function. This usually starts with conservative measures. Over-the-counter pain relievers like acetaminophen or non-steroidal anti-inflammatory drugs, such as ibuprofen, can be very effective. Physical therapy is also a cornerstone of OA management. A therapist can teach you exercises to strengthen the muscles around the joint, which can provide more support and stability, thereby reducing pain. For the most part, frequent blood monitoring is not a major part of OA treatment. The treatment strategy for rheumatoid arthritis is far more aggressive and complex because the goal is not just to manage symptoms, but to stop the underlying autoimmune attack. We need to actually change what the immune cells are doing. This requires powerful medications known as disease-modifying anti-rheumatic drugs, or DMARDs. Some of these, like methotrexate, are forms of low-dose chemotherapy that work by suppressing the overactive immune system. We also use a class of drugs called biologics, which are highly targeted therapies that block specific signals involved in the inflammatory process. And for short-term control of severe flare-ups, we often turn to corticosteroids like prednisone to quickly reduce inflammation. This powerful approach for rheumatoid arthritis comes with a significant trade-off: the need for careful and constant monitoring. Because these medications suppress the immune system and can affect other parts of the body, we have to keep a close watch on our patients. Regular blood tests are mandatory to monitor liver function, kidney function, and blood cell counts. We are always balancing the benefit of controlling the disease against the potential risks of the treatment itself. This is a level of medical oversight that is simply not required for most people being treated for osteoarthritis. The difference in treatment intensity directly reflects the difference in the nature of the diseases. In summary, while both conditions can lead to a painful joint, they arrive there by two completely separate roads. Rheumatoid arthritis is a systemic autoimmune disease where the body attacks itself, often affecting small symmetrical joints like the hands and feet. Its treatment involves powerful immune-suppressing drugs that require vigilant monitoring. Osteoarthritis is a degenerative mechanical disease of wear and tear, usually affecting larger weight-bearing joints like the knees and hips. Its treatment focuses on pain relief and physical therapy. Recognizing this fundamental divide in cause, diagnosis, and treatment is the most important knowledge you can have when confronting the challenge of arthritis.